As noted in the agenda, we will hold the item open. I'd like to thank all the members of the public who came forward to bring testimony. We'll move on to item 5. Once again, Medi-Cal, the Skilled Nursing Facility Quality Assurance Fee Extension, page 37 of the agenda.
Sure. So again, this is another trailer bill proposal. Our proposal would change the sunset date for the rate setting methodology established under AB 1629 originally, as well as the quality assurance fee assessed on these providers, and finally the quality and accountability supplemental payment program. It's currently set to expire July 31st, 2015, and this would extend it to July 31st, 2020. Beginning in 2015-16, the annual increase in rates would be 3.62%. 3.62%, yeah. And the proposal extends the Quality and Accountability Supplemental Payment Program at the 14-15 level, which is about $90 million a year, and it's aimed at tying a portion of payments to facilities who meet specific quality metrics. This proposal ensures the continuation of over $1 billion in funding, including over $500 million in general fund offset through the quality assurance fee. With respect to the question about any assessment we've done on the impact of AB 1629 to quality, we haven't done a specific analysis on the impact of this program on the quality of care. There is some self-reported data to CMS that seems to indicate an increase in quality, but we also acknowledge that there have been, as highlighted in the agenda, very significant concerns about quality issues at some of the facilities, and we are certainly committed to working with our partners at the Department of Public Health as well as others to ensure that Medi-Cal beneficiaries are receiving access to high-quality services that they deserve. And then finally, the question about the level of the rate increase. As I noted earlier, this proposal ensures the continuation of over $1 billion of funding, over $500 million of which is a general fund offset. And so we view this entire proposal as a package that includes the rate increases in order to ensure that we would have a quality assurance fee. Absent this package, there is a significant general fund obligation immediately to the tune of hundreds of millions of dollars.
Thank you. Anything from LAO on this item? Department of Finance? Any public comment on this item? Please come forward. We will ask, as is our practice today, 2 minutes or less. Please introduce yourself. Thank you.
Yes, I'm Charlene Harrington. I'm a professor at the University of California, San Francisco. And I'm also here representing the California Advocates for Nursing Home Reform. In looking at the history of this legislation, we don't agree that the quality has improved substantially over this time period, even though some of the quality measures which are self-reported, have looked better. The average nursing home in the state receives almost 50 deficiencies over the past 3 years and 18 complaints. And there's a lot of data that shows that a number of the nursing homes have extremely poor quality in the state. And we believe strongly this is because the staffing levels are inadequate. The staffing law was passed in California to set 3.2 hours per resident day in 1999, and it hasn't been increased since that time period. And this legislation, the reimbursement rate, was designed to give facilities an incentive to increase their staffing, but they only increased staffing by a fairly small amount, not in keeping with the rate increase. And wages went up a little, but again, not substantially. So we would like to see this legislation tied to a mandated increase in staffing phased in over the next 5 years. That would get us up to what the experts say is a reasonable staffing standard, which is a minimum of 4.1 hours per resident per day and 1.3 licensed hours per resident per day, of which 0.75 of those hours would be RN hours. There's over 100 research articles that show that the strongest predictor of quality is the staffing, particularly RN staffing. So we hope that you would tie the increase in rate to the staffing, which would pay for it wouldn't cost extra money to add the staffing. Thank you.
Thank you.
Deborah Doctor, Disability Rights California. I want to support what Dr. Harrington said. I was here at the beginning of this in 2004 when AB 1629 was passed. We opposed it because we were afraid of everything that has come true since then, and we have opposed every renewal. And the irony is, can't be lost on us that we just heard from a string of MSSP providers who have never been accused of harming, neglecting, and abusing their residents, and they're starving. CBAS programs, same thing, shining records of care, and they've been starving so much that many of them have gone out of business. On the other hand, we have a nursing facility industry whose income has increased by the grace of the taxpayers about $1 billion per year for the same amount of people over the last 10 years. This is a portion of that, a substantial portion is general fund money. That means that the state is making a policy decision to fund institutions and starve the services which people prefer, which are cheaper and coincidentally are their rights under the Americans with Disabilities Act. This funding benefits nursing home operators. It does not benefit the residents of the nursing homes. And it should not be state policy to prop up that our policy goal is to enrich the nursing homes. There are not just two choices here. The choices are not binary. It's not that either we give them more money every year or the other choice is they withhold a quality assurance fee. You have more choices than that. And I urge you to make the choices that follow what I know to be your values, which is supporting the interests of the people who need the services, not of the business people who own the services. Thank you.
Thank you very much. Next.
Carol Sewell from the California Commission on Aging. We'd like to thank your consultant for the reference at the very end of the analysis to the possibility of giving some of the QA fee money to the long-term care ombudsman. If we're going to try and improve the quality and assure the safety of residents in these facilities, one way to do that is to make sure that the ombudsman has the adequate funding they need to do the service they provide. Thank you.
Thank you. Next.
Jennifer Snyder on behalf of the California Association of Health Facilities. We are in the association that represents about 800 skilled nursing facilities in California, 500 intermediate care facilities for the developmentally disabled. We are supportive of the governor's proposal, which would extend the quality assurance fee that providers, nursing home providers have chosen back in 2004 to assess themselves. And it also supports, also supporting the investment going forward at a 3.62% investment going forward in the Medi-Cal program for nursing facilities. We think it's essential to making sure that we can continue to provide quality care and increase staffing in our facilities. I would respectfully disagree with a couple of the speakers before me about the quality that has changed in nursing facilities and the amount of increase in staffing. We have seen a substantial increase in the minimum staffing level in skilled nursing facilities back in 2000 or before 2004, when the 1629 program was put in place. Staffing was below a 3.0 minimum. We are now at an average of 3.73 minimum staffing level. We've seen an increase in employee benefits and wages at 36%. We've seen a reduction in turnover by about 15%. We're seeing quality improve in facilities. Back in the year 2000, we were seeing facilities go bankrupt. We had incredible problems with quality. Now we've seen a reduction in 44% in citations, 24% in deficiencies. CMS is ranking California facilities in the 17 rankings that they do on quality in skilled nursing facilities. California ranks #1 in 3 of those categories and in the top 4 in 4 others. We always need to improve that, we always need to make sure that we continue to move our members forward to be better providers. But the 1629 program has been essential in making those facilities viable and making them, giving them the ability to provide more quality. Part of the cost-based reimbursement system that was created back in 2004 does reimburse facilities at the 90th percentile for the investments that they provide in staffing. It is the highest percentile that facilities are reimbursed for in their costs that they report to the department. It was meant to incentivize facilities to continue to increase that staffing level, and they have done so, and I believe they will continue to do so. I think that's fundamental. The 3.62% that the department is proposing, the governor's proposing, really gets those facilities back to what they consider to be their costs. Right now, they're paid at about 93 cents on the dollar, and the 3.62 over 5 years gets them back to whole. If we want to talk about additional staffing requirements, a new minimum in staffing for facilities, that needs to be done outside of the guarantee that the governor's proposal has provided. The association is always open to talking about staffing, but that is additional costs that would have to be borne by the Medi-Cal program if we want to talk about staffing. Thank you.
Thank you very much. Next speaker, and please 2 minutes or less. Thanks.
Yes. Good afternoon. My name is Hester Kleinstecker. I am the program manager of the Office of the State Long-Term Care Ombudsman, and I'm here today to express our support for the Cantor proposal that would tie any increase in Medi-Cal reimbursement rates to nursing homes to an increase in the minimum staffing requirements for nursing homes. We also support their proposal to increase our appropriation from the Quality and Accountability Fund. This is crucial to support our local long-term care ombudsman programs who are out in the facilities on a daily basis and are still more than 25% below the state and federal funding that they had back in 2008 when they lost all of their general fund. So we support the staff recommendation to hold this item open while these issues are discussed. Thank you.
Hello, my name is Karen Jones. I'm the program manager for the local long-term care ombudsman program in San Luis Obispo County. I'm also a board member for the California Long-Term Care Ombudsman Association. We strongly support seeing increased staffing to come with this, and we also would beg you to please consider adding additional funds to the ombudsman program from this fee. The legislative intent when it was written is very clear. It's not just intent, it's in the language to continually increase the amount of income to the ombudsman program, and that has not happened one time. So while other groups have gotten increases through this fund, we have not seen one. And our services suffer while we could be providing services to make sure residents have that quality of care. We have a lot of programs who just cannot do their job, and we really want them to do their job. Thank you.
Minutes.
Madam Chair, members, Gary Passmore with the Congress of California Seniors. Several comments. The first one is that we do support the governor's proposed funding level and other recommendations for the nursing home industry and the AB 1629 program, which we supported in 2004. We also would like to see higher staffing levels because we agree that they improve quality of care. And we also then acknowledge that it's likely that it's going to cost more money in the long term to do that, and we would support that if that proposal came forward, either from the legislature or from the administration. And then finally, I would like to say we also strongly support the allocation of some of the QAF funds for the long-term care ombudsman. They provide an important service that actually helps the state meet some of its obligations that the Department of Public Health has been struggling with. Thanks.
Thank you. Next witness.
Madam Chair, Robert Harris on behalf of SEIU California. We strongly support the staff's recommendation to leave this item open, and we support it for several reasons. We think there are some flaws in the proposal. One, the administration's proposing to freeze the supplemental payment amount for the QAF after only 2 years of giving them out when they were intended to drive quality improvement in the system. We think it should be allowed to go the 1% a year as it was designed, because we need to establish whether the criteria we put in that actually drives quality. We think it's moving in that direction. Our workers who work in the homes notice a difference between the ones who get the supplemental payments and the ones who don't. The second thing that's really important to us is staffing. Our members, 15,000 members who work in nursing homes across California, have come to us and said, we're understaffed in a lot of the homes, and when we do that, we can't give people the kind of care that they deserve. And we run around like chickens with our heads cut off, but we can't do it. So we think that staffing is important. Staffing drives quality. Everybody knows that staffing costs money. Now, we aren't only giving the facilities the 3%, or it's proposed to give them not just the 3%, that was the original intent, but to give them 3.62. So the extra part to make up for something they lost over the downturn in the economy. But we aren't proposing that for any other Medi-Cal provider to make up for what they've lost over that period of time. You know, so that just seems blatantly unfair. We aren't right now doing it for IHSS. We aren't doing it for the health plans. We aren't doing it for doctors. You know, there should be some equity, and if there's extra money to give them that, why not use it to drive up staffing? So that's what we think. We think, oh, one other thing. As part of the formula, of how we got to the supplemental payments, it was staff retention was one of the things that's in the law that was never implemented because the Department of Public Health, not this department, said they couldn't do it. The industry now says they can track that. They've got records for how it's done, so that should be part of the formula. Thank you.
Thank you, sir. Next witness, 2 minutes, please.
Hi, I'm Cheryl Simcox. I'm with the local ombudsman program. We cover 7 counties in this local Sacramento area. We definitely would support the funds being tied to increased staffing in nursing homes. We've been out there, I've been out there, and we see quality assurance sometimes is just a really nice way to make us feel better, and we've seen it. We need the additional funding to ensure it and improve. We've got a 77% resolution rate when we're out there in the facilities and ensuring that the quality of care is being addressed. Thank you.
Good afternoon, Lisa Coleman with CalCOA, the California Long-Term Care Ombudsman Association. We did submit a letter supporting this bill with 2 amendments to increase the staffing and also to recognize the original legislation's intent that this be an ongoing increasing source of revenue for the Ombudsman program. We recognize that it is a tight budget. However, our advocates are doing a great job. They provide a good service, and it's a good bang for the state's buck. We ask that you support the bill, but with the 2 amendments we've requested. Thank you.
Thank you very much. Appreciate that. And we will be holding this item open as well. Oh, I'm sorry. Yes, Senator Monning.
I didn't ask this earlier, but after hearing the testimony, nobody seems to argue with increased staffing ratios to be a benefit. But is there a required proportion between the more highly skilled nursing staff and nursing assistants? And when we talk about increasing staffing ratios, is there a built-in indicator of how many of those would be higher trained versus lesser trained?
Unfortunately, that isn't actually my area of expertise. That's really our Department of Public Health, so I wouldn't want to say anything because I probably would say something wrong.
Okay. Well, maybe somebody else is familiar with that, and because when we talk about increasing staffing ratios, that sounds good, but we also have in the staff notes at page 38 research that shows you have better patient outcomes when you have a higher ratio of registered nurses, licensed vocational nurses to other nursing personnel. So do you have a comment on that? Thank you.
Charlene Harrington. Yes, the Centers for Medicare and Medicaid Services did a study in 2001, and they came up with the recommended standard for total nurses for RNs, LVNs, and nursing assistants. And we would like to see us hit that target and to increment it up over time. It's kind of the gold standard for what they recommend.
Thank you very much. That's helpful. Thank you. Thank you, Madam Chair.
Thank you. Anybody else wanting to respond? Okay, thank you very much. We're going to move on now to the Managed Care Office of the Ombudsman, page 39 of the agenda.
Sure. So this is a request for 9 positions to help address the added increase in call volume to our Office of the Ombudsman. We have seen our call volume increase by 71% in 2014. And the increase in volume has resulted in members receiving busy signals, calls going unanswered, and the need to leave voicemails and actually ending up having people call multiple times. And so we believe that these additional staff are necessary in order to help us handle the level of calls that we're receiving. The agenda also asks us a little bit about our new phone system that we are working on implementing with our target still of by the end of June 2014. The new system will help the office better manage the call volume, reduce members having to call multiple times, and allow supervision of callers in the queue to provide better customer service. The staff will be able to help more members by having them focus on actual callers rather than having to expend time returning voicemails. And as I mentioned earlier, a lot of times what happens is once we do return a voicemail, it turns out the individual has already had their issue resolved because they did call the office multiple times. The new system will also eliminate the busy signal that is currently occurring for our current phone system. We are in our final stages of purchasing the new system, and we are still targeting the deployment by the end of June or shortly thereafter, and we'll continue to work with the vendor, it's AT&T, to ensure a fully operational system before we actually transfer from our existing to the new one. With respect to the performance standards, since we are going to be moving to this new system, we don't have anything specific set yet. What we think we need to do is really look at how things are working in the new system, figure out what are the right metrics to look at, so then we can turn around and use those as standards to increase the responsiveness of the office.
LAO, Finance. Public comment, please, 2 minutes.
Linda Way with Western Center on Law and Poverty. We support the staff recommendation to support the proposal to add additional staffing, but question whether the 9 additional staff will be sufficient. We've heard from our legal aid advocates that they've had difficulty getting through when calling on behalf of their clients. We also would support the need for additional data with the new system coming up.
Next witness.
Tam Ma with Health Access California. We very much strongly support DCHS's request for staffing support for the Ombudsman's office. We are very concerned about the office's capacity to handle the calls and help beneficiaries navigate and get the help that they need from their health plans. A couple of years ago, we did a secret shopper survey of all of the different consumer hotlines across the different state agencies, and DHCS's call centers had among the longest wait times at the time, and we think that these resources are very much needed. We also hope that the new telephone system will improve services and provide the data that will allow the Office of Patient Advocate to be able to analyze and report on the data from all the different consumer service centers so that we can understand what's going on, whether consumers are getting the assistance that they need, and we urge the committee's approval of this item. Thank you.
Thank you very much. Senator Monning,
We have one more.
No, she's going out the door. Thank you. We will accept the staff recommendation to approve this request. Moving on to item number 7. Item number 7. Yeah. The Medi-Cal impact of the President's executive order, page 39.
Sure. So there remain many unknowns about this, particularly given as noted in the agenda, the court action that halted implementation of the order. We are continuing to assess the information, and certainly the information that came out recently in the report that was cited is helpful in that assessment. I do want to say, obviously, that there are currently no plans to change current Medi-Cal eligibility policy, and so today individuals who are in a status like deferred action are able to enroll in full scope Medi-Cal if they meet other requirements and they follow the appropriate processes. So therefore it is potentially possible that the order could increase the number of individuals, and we'll continue to assess that and obviously have that ongoing discussion as part of May revision.
LAO.
Amber DG, Legislative Analyst Office. Committee staff did a nice job of summarizing our findings in the agenda. So just briefly, we find that there's considerable uncertainty both from a legal perspective and a political perspective as to if and when the actions will be implemented. And based on that, we find that there are likely partial year and minimal, if any, costs to be faced in 2015-16 as a result of the actions.
Thank you very much, Finance. Senator Monning. Public comment, please, 2 minutes or less.
Beth Capel on behalf of Health Access California. We're very pleased to hear the administration acknowledge that persons who are eligible for deferred action are also eligible for Medi-Cal if they are also low income and otherwise eligible. We would like to thank the administration for their help in trying to sort out enrollment of those who were previously made eligible as a result of deferred action. There have been a number of barriers to getting those folks enrolled in Medi-Cal even when they've been granted deferred action. We are somewhat more optimistic than the legislative analyst or the administration about the prospect that the courts may act soon during the budget year, thus allowing people to proceed to deferred action, and for those for whom they are low income and eligible also then proceed to Medi-Cal. Happily, if you read the UC study, you will find that many people who are granted deferred action get work permits, get better jobs, and some of them even get health insurance on the job. Those are good things that are taken into account in the estimate that is in your analysis of about 350 to 500,000 potentially eligible and enrolling. Thank you.
Is there something that you can share that makes you more optimistic in terms of the ruling?
The current action of the Federal Department of Justice to seek an emergency stay, and obviously this is working itself through the courts, it is possible. And all of the legal scholars in the immigrants' rights communities tell us that the president's action was well within the bounds of executive action, and that for the court to undo it would require undoing executive actions going back to President Washington, which seems to be rather a long time ago.
Yes. Woo! Yeah, Senator Monning said that President Washington would not like that. Thank you for that clarification. Appreciate it. Next witness, please.
Linda Way with Western Center on Law and Poverty would like to align my comments with Beth from Health Access, Ms. Cabell, in thanking the administration as well as voicing our optimism that deferred action could, that this status could be granted within the budget year, and so believe that it should be included in current Medi-Cal estimates.
Thank you. Next witness.
Gina De Silva with the California Immigrant Policy Center. Also would like to echo Beth's comments and thanks to the administration. Just pointing out that even when these programs do roll out, and they will, that a huge population will still be left out of deferred action and lack access to care. So really thinking how the state can consider that population and making sure that everyone in California has access to care, because we all know that we're a stronger and healthier state when we do. So just thinking about the investment and also the investment around ensuring that immigrants that are eligible for deferred action are able to access it and access health care through Medi-Cal if they're income eligible. But also, as Beth referred to, they're going to get work authorization, and most will be able to access health coverage through employer-based coverage.
Thank you very much. Next witness.
Jeanette Sonny-Pathine on behalf of MALDEF. Also want to align my comments with the previous speakers. Really want to thank the administration for extending Medi-Cal for deferred action. We are optimistic, as Beth mentioned, that this will get resolved sooner, and so we might see DACA and DAPA roll out hopefully before the end of the year, and therefore we should be kind of factoring that in our budget conversations, but also would like to echo the previous testifier as well in terms of ensuring that all folks who are California residents actually have access to health care. Not everyone is going to be able to be eligible for both DACA and DAPA, so we really need to kind of think about what kind of state we want to have and ensure that we have access for all, regardless of immigration status. Thank you.
Thank you. Next witness.
Michelle Stoll-Parvensky, Children's Defense Fund, California, also on behalf of the Children's Health Coverage Coalition, which includes Children Now, Children's Partnership, California Coverage and Health Initiatives, PICO California, and United Ways of California. Would like to align ourselves with the previous comments as well, and we thank the administration for their commitment to ensuring that those eligible for deferred action have access to comprehensive Medi-Cal coverage. We know that when parents have health coverage, there are a huge amount of benefits for children in terms of them being able to get covered and get care regular care, immunizations, checkups, and so we strongly support this. Would also underscore that even after this is implemented, there's 170,000 children in California who remain uninsured due to immigration status, and would encourage movement forward to figure out how to provide coverage to those children. Thank you.
Kathy Dressler with the Children's Partnership, also a part of the Children's Health Coverage Coalition that Michelle was just describing, and also on behalf of the 170,000 children that will be without coverage until we grapple with this and have health care for all Californians. Thank you to the administration. So we look forward to working with you on making sure that we have coverage for the deferred action folks.
Next witness.
Kimberly Chen with the California Pan-Ethnic Health Network. Just want to align CPEN with the comments of Health Access, Western Center, and CIPC. Thank you.
Gary Passmore, Congress of California Seniors. Two things. One is to remind you that not all older Californians end up in Medicare. Some aren't eligible and can't get there. And also that one of our goals as an organization is to try to make sure every Californian has access to quality and timely health care. We're strongly urging the administration to recognize this as an appropriate next step in covering California. Thanks.
Thank you, sir. Senator Bonnie.
Thank you, Madam Chair. I also just want to add my word to those that have been offered of our appreciation to the administration for recognizing this potential new category of eligibility dependent on the court action. And as has been said by other speakers as well, our broader public health is dependent on access to health care for all. And when we start creating silos of exclusion or eligibility, it reduces the broader public health of the state. So my appreciation, our appreciation to the administration for forward looking on this. Thank you.
Thank you very much. And we will hold that item on page 41 open. Moving on to item number 8, Medi-Cal continuation of the 1115 waiver workload, page 43.